Next up is Dr. John Rubin. Dr. Rubin is Assistant Professor of Clinical Anesthesiology at New York Presbyterian Hospital, Weill Cornell Medicine, and also the Assistant Director of Education for Academic Assistants within the Anesthesiology Residency Program. So Dr. Rubin, please give a round of applause.
Thank you, Will. It's an honor to be here. So today I want to talk to you all today about leveraging spatial computing for soft skills training and simulation in medicine. And I have no disclosures. So just a brief outline what we're going to talk about today. We're going to talk about how we teach today, and then talk a little bit of how we can use artificial intelligence for both simulation education and for standardized patient encounters. So I'm an anesthesiologist, and anesthesiology is an acute care specialty. I don't just put people to sleep. I'm actually in charge of everything that happens in the operating room. So if a patient has a heart attack on the table, or if they have an allergic reaction, or somebody starts hemorrhaging during surgery and they need blood, I'm the one that treats all that. And so I'm the one who keeps the patient alive and facilitates the conditions so that a patient can have surgery. And obviously, things happen rapidly in the OR, so I have to be able to have the capability of dealing with crises rapidly as well. And everyone who's ever trained to be an anesthesiologist, or I would say a physician in general, knows exactly what this is like, because this is how we teach today. We throw people into the fire, and then we hope they come out alive. More specifically, our current model is an apprenticeship model. And so for anesthesiology, that involves 4 years of residency training, and then after medical school, and then typically a year of fellowship training after that for a specialty. And throughout all that, our trainees carry out clinical care and perform procedures under the direct supervision of attending anesthesiologists. So again, this is the tried and true form of training, and it produces excellent physicians, but it can absolutely be improved. And what we want to do is transition to deliberate practice. What is that? It's an interaction between knowledge acquisition, skills training, and feedback. And essentially, the trainees get practice before they even interact with a patient. So here, the trainees are still going through an apprenticeship, but now deliberate practice facilitates more efficient patient encounters. This is one form of deliberate practice, and that's what simulation education. This is our sim lab at Cornell. Simulation is crucial in anesthesiology, especially for rare events like malignant hyperthermia. These are things that an anesthesiologist may only encounter once or twice in their life, but they need to be able to recognize it immediately and deal with what's happening. So simulation, as I said, is a form of deliberate practice, but there are problems with simulation. First, for one thing, with physical simulation, it's extremely expensive and time-consuming. And because of that, you basically only get it during medical training. And so once you're done with training, like me, you don't have access anymore to it. And lastly, you can't do simulation on demand. There's no way to simulate something for an upcoming clinical need. So we all know that simulation is a crucial part of the safety culture in medicine. We've seen significant improvements in patient outcomes as a result of simulation. And we see that in medicine through ACLS training as well. And we see that in aviation. So the question is, if simulation is so important, then, and yet it's so resource intensive, how do we scale it appropriately? Well, we think one way to do this is with spatial computing. We think that's the most efficient and effective way. So we can do simulation in virtual reality. It allows for asynchronous learning. And it also allows us to create characters using artificial intelligence to create high-fidelity, multidisciplinary simulations. So having laid the foundation for deliberate practice and hard skills training in physical simulation, I want to talk a little bit more about soft skills training. So what is soft skills training? Soft skills training is types of interpersonal skills like communication, teamwork, and conflict resolution that are so crucial for clinical practice in medicine. And obviously having soft skills training is equally important, possibly even more important than hard skills training in some ways. Well, we want to train physicians who are empathetic, who are strong communicators, and who can best serve their patients. And one way that we can teach people or informally evaluate them for training is through standardized patient encounters. So OSCEs, like I said, are very important. They're actually so important, by the way, that we have them every stage of our medical training, including on the final board certification in many specialties, including my own anesthesiology. So there again, these are another form of deliberate practice, but they require tremendous amounts of time and resources. You need to have the actors, you need to have the proctors, you need to have the examinees. You need to be able to grade the encounters. You need time both for the proctors and the examinees to be free of clinical responsibilities. And you need to train the actors, which takes about 8 hours a month. And again, just like medical simulation, this model is extremely difficult to scale. But what if we leverage spatial computing to enable us to perform OSCE encounters at scale and possibly to even grade the OSCE encounters? So I want to show you some examples of what is possible with this. These are some new examples, and so we're going to just show you in text interactions here. This is obtaining an HPI and also obtaining patient consent for a procedure. So this is a character we created. This is Emily. Emily is a 35-year-old woman who's the vice president of marketing for Barclays. She's currently in active labor, and the task here is to speak to her about obtaining consent for an epidural. And so I'd say, Emily, how's your pain right now? She said, it's about a 10 out of 10 to be honest, and I'm really anxious about pain of childbirth. I've been researching my options. I said, sure, tell me about what you've read. Well, I've stumbled upon this blog that talked about the risks of getting epidural during labor. It mentioned some scary stuff like the possibility of paralysis from the waist down and also potential link to autism in children. And then I had a friend who had an epidural. Now she's really dealing with back pain, and it's got me a little worried. Now, you may be thinking, this type of response is a little bit over the top. I'm here to tell you it's not. I was just on L&D on Thursday night, and or Tuesday night rather, and I can tell you that these are exactly the type of questions that come up every day when we talk to patients about having an epidural. This is another example. This is Julia, and Julia is actually the exact same patient as Emily, except I changed her name for simplicity. The only difference between Julia and Emily is that Julia just had an epidural placed on her. Now, sometimes, instead of obtaining consent, we have to disclose a complication. Well, it turned out during the placement of an epidural, sometimes the needle advances a little bit too far, and patients are at a high risk of developing a very severe headache for a few days. We call this a post-dural puncture headache. So the task here was to disclose this to Julia. So I said, Julia, how's your pain now after the epidural? She says, actually, the epidural's helped a lot. I'm feeling a lot more comfortable. Well, the other reason I'm here is that I wanted to speak to you about something that happened when we placed the epidural. She said, oh, really? What happened? I thought everything went smoothly. She said, well, your epidural's in place and it's working well, but when we were placing the epidural, I noticed that some fluid was coming out, and that concerns me that you may be at risk for developing a headache over the next few days. Now, again, I want to emphasize this. We, especially in anesthesiology, but I think this is probably true for all medical specialties, we are terrible at disclosing complications to patients. So simulated OSCE like this, where trainees can practice this whenever they want, possibly right before they have to do it, is invaluable. One last example I want to show, for now, I want to show you is talking about advanced directives to patients. As I said, I'm an anesthesiologist. I actually do this every day in my job, and it's a very difficult task that, again, we do very poorly. I want you to meet Joe. Joe is a 63-year-old firefighter from Staten Island. He has metastatic lung cancer and has an active DNR/DNI. But he has a small bowel obstruction, and he needs an exploratory laparotomy in the middle of the night to fix it. So that's a reversible condition, but Joe will need to be intubated for the procedure. So here I say, Joe, I'm Dr. Rubin. I'll be your anesthesiologist tonight. I'm sorry that we're meeting under these circumstances. I said, I ain't got much joint, doc. Let's get this over with. Well, before talking to you about my plan for anesthesia tonight, I saw on your chart that you have an active do not resuscitate order. Is that correct? He says, yeah, that's right. I don't want to be kept alive if my time's up. Okay, that's good to know, but the reason I'm asking is because when we do surgery or do anesthesia in an emergency, it often requires what we call general anesthesia. And that would be where we place a breathing tube. So it'd be temporary, but it'd be necessary to keep you safe during surgery. Is that something you might be consistent with your wishes? And Joe says, look, doc, I don't want to be hooked up to no machines, but if I also don't want to choke on my own spit if I can't breathe. So you tell me how to keep that from happening, and we'll talk about the breathing tube. So obviously Joe's character is a bit more gruff than Emily and Julia, but this encounter allows the trainee to practice having these difficult conversations with patients. I've shown you 3 examples of OSCE scenarios that we've created using large language models. And this simple text interaction that you've seen is pretty effective. But what if we incorporate extended reality to make these experiences even more impactful? When you enter, I can tell you from experience, and when you enter into a virtual environment and sit across the space from a virtual patient, it really does feel like you're sitting across from another human being. I want you to meet Carl. We created Carl, so this is an example of an integrated interaction for the purposes of empathy training. Carl is a conversational agent we created to help us trainees better understand chronic pain. He's a 33-year-old man who has sickle cell anemia. And unfortunately, we have a lot of patients at my institution who have sickle cell, and they are a very stigmatized and challenging patient population, as I'm sure many of you know. So the question is, can we learn to better treat our patients with sickle cell anemia by learning more about them and therefore gaining greater empathy through our interactions with them with AI models like Carl?
Hey Carl, what medications are you taking for your pain?
Oh, the epidural. So I'm epidural. I'm on opioid therapy for last quarter century, and so forth. He keeps pain at bay, but sometimes I feel like people are treating me like a junkie.
Yeah, I can sense your frustration in your voice. Is there anything that I can do as your doctor to make your life a little better?
And that's something that we hear a lot from our sickle cell patients. They just want us to listen to them. So again, many of these encounters may seem straightforward to create, and I can assure you that they are not. We have a bit of a methodology for this. So first, we use an underlying software that uses compound large language models. Then we create a narrative for the character and the situation. We build the character's personality. And lastly, we test the characters repeatedly to provide it feedback on the answers that it generates. And ultimately, what is most important here is the element of realism. These interactions have to be realistic to provide our trainees an interaction that it is at least non-inferior to what they would experience with a standardized patient. So the clips that I've shown you of the interactions so far, they went very smoothly because I've been an attending anesthesiologist for 3 years and I'm pretty good at having these conversations. What's truly remarkable is to see the range of responses when we test this with different trainees at different levels that engage with those characters. So just an example, with Emily, I had one of my junior residents speak to Emily about a labor epidural, and the encounter went so poorly that Emily requested to have the, quote, most senior provider place the epidural instead of the trainee. And in the business, we call this an attending request. I want to emphasize that was not in any way, shape, or form part of the character we created for Emily. But it still happened, and I have the transcript to prove it. So briefly, I want to discuss the concept of debriefing. Debriefing is the feedback component of deliberate practice, and it's a crucial part of simulation education. In fact, some people argue that there's no point of doing simulation unless you can effectively debrief your students. So we need to figure out how to debrief in extended reality as well. Right now, we do it with human proctors. Can AI-based proctors also be useful? And also, how do we grade these encounters? Again, right now, we require human graders, but can we also create an internal AI grading software? And then, if we do, how are we going to validate those AI models? Are we going to be using convergence testing or some other methodology? So these are important, outstanding questions related to the implementation of spatial computing in simulation education. The last point I want to make is really crucial. So one thing that my colleague Rohan Jatwani and I discovered over time, really through feedback, is that overwhelmingly, our trainees want simulation education and training at a larger scale than what they're seeing now. But they want high-fidelity, guided experiences. Nobody wants to be placed in the fire with the hopes that they will figure it out. These spaces can be very confusing and frustrating for people with limited technological experience. So ultimately, the creation and widespread adoption of medical extended reality will require skilled teachers to come up with the lessons and facilitate high-quality debriefs that provide people the highest quality experience. The knowledge and skills that our trainees gain will be only as good as the lessons we create. So in the future, there are a number of things that we need to do. We need to, A, learn to develop a new pedagogy for how we teach in extended reality. We need to quantify our results to see if there are improvements. At the very least, that they're non-inferior relative to standardized patient encounters. We need to further incorporate extended reality into the experiences that we create so that our trainees can have the highest impact. And we need to create models that are diverse to teach our trainees how to better deal with inherent bias. Ultimately, this technology is improving rapidly, and the future is exciting. We have the capabilities now to do amazing things. All it takes is an idea and the will to implement it. And with that, I'm happy to take any questions you may have.
Let's give a round of applause. So, thank you, Dr. Rubin. We have time for one question. All right, what's the question?
Thank you so much for the great talk. I'm wondering if you can elaborate a little bit about how you created those conversational interactions and what the compound LLM is. And have you done anything on the debriefing and the scoring and feedback part? Thank you.
I'll answer the last question first. We haven't had a chance to really work on the debriefing and scoring part yet. That's something that we're going to do when we get back to New York. As it relates to how we create it, we use a gaming software that uses compound large language models, and then we encode the software through Unity.
All right, well, I think that was a very nice answer. Give another round of applause for Dr. Rubin.